Hello, this is Nicholas Courtney with the National Congress of American Indians. We will begin in 30 seconds. Hello, this is Nicholas Courtney with the National Congress of American Indians. Thank you for joining us for our second webinar on the overview of the Affordable Care Act and benefits of AI and marketplace enrollment. Today, we will be talking about CMS programs benefiting American Indians and Alaska Native individuals. I have the distinct pleasure of introducing Donnig McDonough of Health System Analytics, consultant to NCAI, and technical advisor to the Tribal Self-Governance Advisory Committee. Before beginning our webinar, I'd like to discuss a few housekeeping items. You will all be using GoToWebinar platform. On this platform, you can open and close your panel using the orange arrow. You will also be able to view, select, and test your audio. However, for this webinar, we have disabled this feature due to the number of participants. If you would like to reach out to us, please, we encourage you to do so using the questions text box. This webinar will also be recorded and made available on our Policy Research Center website, YouTube channel, and tribalhealthcare.org. Without further information, please, I'd like to introduce you to Donnig McDonough.
Thank you, Nicholas. Appreciate the opportunity to present some information on the Affordable Care Act, in particular what the benefits are to American Indian and Alaska Native enrollment through a health insurance marketplace. As you see on the slide, we'll have four sections here. One is reviewing the ACA provisions in general. Second is the benefits enrolling through a marketplace and the level of enrollment of American Indians and Alaska Natives to date under the Affordable Care Act. Third is having a discussion about tribal sponsorship, which is one tool that tribes have used to increase the enrollment.
We apologize for any technical difficulties.
Section 3, we'll talk about tribal sponsorship, which is a fancy term for a tribe or tribal health organization paying the health insurance premium of a tribal member or other IHS-eligible individual. And in this case, we're talking about securing coverage through a health insurance marketplace established under the Affordable Care Act. And then the final section, we'll look at a couple examples of tribal programs with sponsorship and how those have turned out. Just one second. Great. So we've got a couple slides just as reference. So on this slide here, abbreviations that we will see later in the presentation. As Nicholas mentioned, CMS, that's the Center for Medicare and Medicaid Services, which is the primary agency in the federal government within the Department of Health and Human Services. And under that is CSIO, which is an even longer name, Center for Consumer Information and Insurance Oversight. Those two entities in the federal government have responsibility for operation of the marketplaces that we'll be talking about here. On the next slide, another reference is to the dollar value for the federal poverty levels, and these apply to many of the marketplace provisions. Eligibility is determined by household income as well as some other factors. And so you see those here with the marketplace FPL, federal poverty level R, for securing eligibility for either cost-sharing protections, out-of-pocket costs, for instance, or for premium tax credits that might be made available to an individual who enrolls in health insurance coverage through a marketplace. Just one comment here. These are the 2018 federal poverty level guideline figures, and they are used for the 2019 marketplace enrollment. For Medicaid purposes, it's the 2019 FPLs used for 2019 enrollment. So there's a little bit of a difference in those. The dollar amounts, though, do not change a great deal from year to year. They just change slightly. So that's a reference for the federal poverty level, and by household size, what is the actual income level there. We'll walk through on this slide the general provisions that are in the Affordable Care Act, and then we'll get into some data that are specific data for American Indians and Alaska Native, and what the impact has been from the Affordable Care Act. The singular item that's probably, there's two singular items that probably had the most significance for Indian country, and that's the first one and the last one on this list. Medicaid Expansion initially was enacted as a mandatory program that each state would need to implement, with the federal government funding at least 90% of the health care services costs, and even higher than 90% in the initial years. That ultimately, after it went through a court case up to the Supreme Court, it was made optional. So states can expand Medicaid under the ACA authority if they want to, but they're not required to do that. Where it stands right now is, of the 35 states with federally recognized tribes, 21 of those states have expanded Medicaid, covering all individuals in the state, non-elderly residents with income up to 138% of the federal poverty level. For a single individual, it's about $16,000 a year. So 21 states with federally recognized tribes have expanded Medicaid under the ACA authority. That leaves 14 states that have not. So we still have a ways to go in encouraging all states to expand Medicaid, extending coverage to IHS eligible individuals as well as the general population. There were a number of changes in the Affordable Care Act made to the base Medicaid program related to eligibility and health benefits package. On eligibility, probably the single most beneficial provision was simplifying eligibility. And one way that was done was the eligibility criteria, asset tests, how much money do you have in the bank, or do you have more than one vehicle, or what have you. Asset tests were eliminated for the non-disabled, non-elderly population in determining eligibility for Medicaid. So that simplified enrollment quite a bit. The health benefit package was made more consistent across states, but it was also provided greater flexibility in how the state may meet the requirements for comprehensive coverage. Under Medicare, a number of changes there. The most visible may be the fact that those who have Part D coverage for prescription drugs will pay fewer and fewer dollars out of pocket as time goes on. And in fact, we're right now at the point where what was once referred to as the coverage gap or donut hole, that's part of the program where initially an enrollee has coverage that the health plan pays for, and then when they have a lot of expenditures, the health plan pays for coverage. In between a little and a lot, there was a gap where the enrollee had to pay the full price of getting a prescription filled. That's being eliminated over time, and again, I think we're now at the point it's been largely eliminated. A number of other things impact Medicare, which parallel changes in the general marketplace coverage, such as preventive services. For the first time, there's services under Medicaid that are to be provided without copay, a whole range of preventive services. There's a free one-time annual wellness visit that's authorized, which a number of tribes are really making the most of by being proactive, having people come in, getting their annual wellness check, and in that process, looking at whether they have full Medicare coverage, and if not, the tribe may actually extend assistance to an individual to get, say, Part D coverage or Part B coverage for outpatient services. Medicare also had a number of changes on how it pays for services, and those changes are going on now, being tested now, and are continuing. The area that we'll talk about the most Today, on this webinar will be the marketplace. Simply put, the marketplace is a way to go online and to see what options are available in what's referred to as the individual market, meaning you're not in Medicare, you're not in Medicaid, you don't have an offer of coverage from an employer, you're just out there on your own and you want to get health insurance. So the marketplace is a way that health plans are offered to individuals, and they can figure out which plan might be the best for them, and the way the government has structured it to assist people making that decision is they've standardized what the benefit packages are and how much out-of-pocket costs there can be across the plan. So go down to the marketplace, you can compare plans. In the process of kind of looking at what's available, what the premium costs are, how much out-of-pocket, it also is a mechanism to determine eligibility for federal financial assistance in the form of subsidies for the premiums, in the form of premium tax credits, and also some added protections for out-of-pocket costs. And there are provisions for reducing how much someone might have to pay out-of-pocket for the general population, as well as for specific provisions for American Indians and Alaska Natives. Under the Affordable Care Act, the employer mandate was established, which requires employers to either offer coverage or pay the federal government an amount for each full-time employee that they do not offer coverage to. So that's what we often refer to as the pay or play option. And so tribal governments, as well as state governments, nonprofits, and others are subject to this employer mandate if you have more than 50 full-time employees or full-time equivalent employees. You're subject to that requirement. A provision was added that hasn't gained a whole lot of traction, but is there, and you may want to check it out, is for small employers, those with 50 or fewer full-time equivalent employees. They may want to go through a marketplace that's specific to small businesses, the SHOP marketplace, to see if the coverage offered there is more affordable than the options that the employer may have, either self-insuring, which being that small is kind of frowned upon, or buying insurance through a single source health plan. So the SHOP, for some folks, has provided an additional option that is more affordable than the way things were previous to the Affordable Care Act. The last item on the list is a piece of legislation that was combined with the Affordable Care Act and enacted with the Affordable Care Act, but really was developed independent from the Affordable Care Act, and that's the Indian Healthcare Improvement, Reauthorization, and Extension Act. It's making amendments to the Indian Healthcare Improvement Act. One of those amendments was to make it permanent. It didn't need to then be reauthorized every 10 years. And it expanded the provisions and clarified many of the provisions in the Indian Healthcare Improvement Act. So we'll talk about some of those provisions as we go along here. As we go from the general provisions in the Affordable Care Act to kind of the specific impact on tribes and other IHS-eligible individuals, is looking at what's happened with Medicaid enrollment. And we have two tables here. The first one, Figure 1, represents how many additional American Indians, Alaska Natives, and specifically how many IHS-eligible individuals have enrolled in Medicaid over the baseline of what was in place in 2009. So from 2010 forward, what has the growth been in coverage under Medicaid for IHS-eligible individuals? So we see that there's been 115,000 plus IHS-eligible individuals that gained insurance over the levels that were in place before the Affordable Care Act. If we kind of put a dollar figure on what the value is of that coverage, nationally, the average expenditure by a state government for individuals who enrolled in the Medicaid Expansion coverage was $5,600 as of 2017. So put the 115,000 individuals with $5,600 of annual average expenditures, and that generates a figure of over $646 million of expenditures on behalf of these IHS eligible individuals that was not in place prior to the Affordable Care Act. So it's another resource in addition to the Medicaid coverage that was there before, the Medicare coverage that was there before, any private insurance that folks have, and in addition to the annual IHS appropriation, the $646 million is now in the mix as a way of the federal government, in part, meeting the federal trust responsibility to tribes and tribal members. The second table we have there represents what the remaining potential is out there. As I mentioned, 21 of 35 states have expanded Medicaid coverage. If all states were to expand Medicaid that have federally recognized tribes, and if we were to enroll all those that are projected to be eligible, that their income is at 138% of the federal poverty level or less, the figure here, figure 2, estimates what the potential annual revenue amount may be if that were to occur. So this shows an additional $501 million a year in additional health service expenditures may be covered under Medicaid if we were able to do two things. Get the remaining states to expand Medicaid. In the two largest populations of American Indians, Alaska Natives, IHS eligible individuals who live in states that have not expanded Medicaid are Oklahoma and South Dakota. So if we were to get Medicaid expansion enacted in those states and also work more and more, better and better, be more effective than we are today in enrolling eligible individuals, it's a projection there of roughly 89,000 additional IHS eligible individuals gaining coverage under Medicaid. We have data for all the states with federally recognized tribes, indicates which states have expanded, which states have not. On the slide here up at the top, we see Idaho, Nebraska, and Utah. Those are instances where the state has authorized Medicaid expansion. In fact, each of those did that through a ballot measure in the last election, but the state has not fully implemented Medicaid expansion yet in those states, but those will be 3 added to the 21 that will have Medicaid expansion in place that have federally recognized tribes there. So that's on the Medicaid piece, and now we're moving back to a discussion about the marketplace and the value of the marketplace, the opportunity that the Affordable Care Act created by establishing the health insurance marketplaces. I would describe it as one more mechanism that the federal government is using to meet its federal trust responsibility to tribes and tribal members. And we'll go over the next couple slides what the resources are and to what extent are tribal members enrolled in coverage through the marketplace. Just one note is each state has an independent marketplace operating, and it's either the federal government running it or a state. If a state wants to run it, they have the option to do that. If they choose not to run it, then by default, the federal government runs the marketplace. 2 types of federal assistance are available through the marketplace. Premium tax credits, which provide subsidies for the health insurance premium that a health plan that is available through the marketplace may charge. So premium tax credits. And the second are out-of-pocket costs. So go to the doctor, you may have to pay a $10 copayment. You might have a deductible that you have to cover before the health plan starts paying. You may have a substantial copayment amount. If you go to a hospital, for instance, you have an inpatient stay, you may have to spend $1,000 or more. So there are protections in the Affordable Care Act for reducing those out-of-pocket costs for certain populations. One is for the general population, those that have moderate to lower income, up to 250% of the federal poverty level, the out-of-pocket costs are reduced, and then a more comprehensive cost-sharing protections are available to enrolled tribal members. And that is, there's 2 types within this comprehensive protection, but the statement applies to both, is that all out-of-pocket costs, the deductibles, the co-insurance, and co-payments associated with covered services are paid for by the federal government. So if someone were to, an enrolled tribal member were to go to a hospital for a major procedure, there's a deductible of $1,000. The health plan would pay both the base payment for the health services received as well as cover the $1,000 amount that other enrollees might have to pay. And the way that works is with these cost-sharing protections are the federal government makes payment to the health plan for these out-of-pocket costs, and the health plan then pays the provider the amounts that the enrollee, the American Indian Alaska Native enrollee, would have had to pay themselves. So the enrollee doesn't pay it. The provider gets paid though by the health plan, so they aren't disadvantaged at all. And the health plan isn't disadvantaged by making these payments because the federal government makes the payment to the health plan. So everybody gets protected and covered, and in particular, Indian healthcare providers, when a tribal member has insurance but goes to that Indian healthcare provider for services, the co-payment amount historically has just been not charged to the IHS eligible individual. The ITU provider, the Indian healthcare provider, just hasn't collected it. So this is a protection. These comprehensive cost-sharing protections end up serving as a benefit or a protection both for the individual but as well as for the Indian healthcare provider, because now they don't have to just forego that deductible or out-of-pocket costs that the patient's not paying. They will too get reimbursed by the health plan instead of the individual having to pay it. So it's has both revenue potential, benefit to the providers as well as financial protection to the American Indian enrollee in the health plan. There's a couple numbers here. Premium tax credits, national average premiums is about $7,300 a year for the health insurance coverage through a marketplace. But the net premium costs are substantially less. For all enrollees, that $612 a month falls to $143 a month is what the enrollees have to pay, and the federal government pays the rest. But and then if you narrow it down more, for people who are eligible for tax credits and exclude those who are not, the average premium, monthly premium paid by enrollees in the marketplace across the country is $87. Compared that to $612 a month for the full premium cost. And again, the difference between the $612 and the $87 is the amount that the federal government contributes for premium assistance through tax credits. The tax credits ultimately get settled up when you file your income taxes, but when you apply and enroll in coverage on the marketplace, the first month that the federal government will pay directly to the health plan 1/12, 1 month's worth of the tax credit, and they pay that out over time so that the enrollee doesn't have to wait to get their taxes, then refund, and then have the money. It gets paid out immediately over the course of the year. On the next slide, we see for marketplace enrollment, how many IHS eligible individuals have enrolled. We have it broken out by enrolled tribal members as well as other IHS eligible individuals, 2015, 16, 17, and 18. 18 is the data we have from CMS. That's most recent. We'll be getting the 2019 data fairly soon. If we maybe focus on the more heavily shaded area, particularly from 17 to 2018, we see an 18.6% growth in the number of enrolled tribal members enrolled in a marketplace across the country. These are the marketplaces that are run by the federal government, and then we'll have a slide later as well as you see the number below. For the marketplaces that are run by the state, there's an additional 6,800 individuals who are enrolled, tribal members enrolled in state-based marketplaces. But this 18.6% growth from 17 to 18, it was a 20% growth the year before and a 17% growth the year before that. So really substantial and continuous growth in enrollment in the marketplace really represents that tribes and tribal members and other IHS eligible individuals are learning of the benefit of enrolling through the marketplace, that in fact get comprehensive health insurance coverage with an average of premium of less than $1,000 a year. The federal government paying the remainder, and there being no out-of-pocket costs for enrolled tribal members. Just as a comparison, in 2018, for the general population, there was a 0% increase in enrollment in the marketplace compared to the over 18% increase for enrolled tribal members. So I think that's pretty substantial. And one thing it represents is that tribes themselves are entering into using the tool of tribal sponsorship, where the tribe or tribal health organization pays the health insurance premiums, net premiums that the enrollee would pay to help facilitate enrollment. The slide is just going into a little bit more detail on the enrollment numbers that we just talked about. One point I would make, and these are the numbers state by state and for 2017 and 2018, these are considered point in time numbers. So on a certain day of the year, the federal government, CMS, took a snapshot and said how many IHS eligible individuals are enrolled in the marketplace, either enrolled tribal members or other IHS eligible. And so those are the figures that we have. There's a different set of numbers, which is how many IHS eligible individuals enrolled over the course of the full year. Some people may have got insurance and then disenrolled at some point, or they may be enrolled later in the year. So we'll have a set of those numbers as well. But these numbers represent on a particular day how many people are enrolled in the marketplace year by year and by state. So you can see where we've seen growth and where growth is lessened a bit. And just Oklahoma's highlighted there just because it's had particularly strong enrollment growth and overall enrollment being 18,000, almost 18,000 tribal members, as well as another almost 1,000 other IHS eligible individuals there. The numbers on the screen here now are the states that have a marketplace that are run by the state government. We have data for those states only for the enrolled tribal members, not for other IHS eligible individuals. So there's a little bit of a missing data set there, but you can see by state how many individuals are enrolled. For instance, California, 3,208 individuals were enrolled in the marketplace coverage in 2018 there. So a slightly different set of numbers. Rather than how many people were enrolled on one day of the year, the numbers here now are representing how many IHS eligible individuals, either tribal members or other IHS eligible individuals, were enrolled over the course of 2018 is what these data represent. The dark blue are for the federally operated marketplaces and the number of enrolled tribal members. The next block there with the diagonal lines represent federally run marketplace for other IHS eligible individuals, about 43,000 individuals. And then the top box there represents enrolled tribal members in state-based marketplaces where the state operates them. Put them all together and it's just shy of 100,000 individuals, IHS eligible individuals that have secured coverage through the marketplace in 2018. We had the figure earlier about Medicaid coverage. To date, the increase is 115,000 tribal members or other IHS eligible individuals. This is just shy of 100,000, so we've got somewhere on the order of 214,000 IHS eligible individuals that have benefited by the Affordable Care Act's provision since its enactment in 2010. So Section 3, we're going to talk about the tool referred to as sponsorship, where the tribal health organization purchases health insurance coverage on behalf of a tribal member. We're talking about the marketplace, but it also, sponsorship applies in other venues, such as tribe might buy Medicare Part B, the outpatient coverage under Medicare. The tribe may pay the premium on behalf of the individual or reimburse the individual for that Part B premium. Or for Part D, the newer program under Medicare, tribes in some places are paying the Part D premium, getting all tribal members on Medicare having drug coverage, reimbursing them for the premium if they're paying it directly or actually paying the federal government, the health plan directly for that coverage. It then, in general, Part B coverage premiums, Part D coverage premiums represent about 25% of the cost. So 75% of the benefit coming for coverage is paid for by the federal subsidies. 25% would be from the premiums. So put it another way, for every dollar a tribe might spend for Part D coverage, they would get that dollar back and another $3 worth of health service reimbursements for prescription drugs if they were enrolling in Medicare Part D. Obviously, some individuals in a year would have healthcare costs less than the average. Some would have healthcare costs much more than the average, but on average it works out. The premium that the tribe might pay would be about 25% of the overall expenditures, and the federal government would pay the other 3/4. So goals of sponsorship: generate additional resources to meet the healthcare needs of tribal members, but also make health services more accessible to tribal members. And one example of that might be you're enrolled, say, in the marketplace, and you're on the weekend, and you and your child's enrolled as well. You need to get a prescription filled. If the tribal facility or IHS facility is not open, you can as easily just go to CVS or another commercial pharmacy and get it filled on Saturday or Sunday or in the evening or in the middle of the night. And through the marketplace, enrolled tribal members would be able to do that without having to pay for the prescription itself or have any out-of-pocket costs. So services oftentimes can be made more accessible by doing sponsorship through health insurance coverage. Shown there in bold at the bottom of the slide is making the point that tribes that have engaged in sponsorship have put this tool in effect whereby the tribe would pay the enrollee's portion of the premium and thereby bring in other resources, typically from the federal government through the marketplace or through Medicare. On average, for each dollar invested by the tribe in paying those premiums or running the program itself, tribes have been getting back $4 to $5 in health service resources, either revenues, services that were otherwise uncompensated because the individual wasn't covered for it, or savings in their PRC programs if the individual had to go outside of the tribal system to get healthcare services that aren't available within the tribal or IHS system. So again, on average, looking across the programs that have shared data with us, average return to sponsoring tribes of $4 to $5 in health resources generated from PRC savings or actual cash generated in third-party revenue for every dollar invested by the tribal sponsorship program. For those that are tribes that are interested, tribal health organizations that are interested in doing sponsorship, there's a host of resources out there, in particular on the Tribal Self-Governance Advisory Committee website, tribalselfgov.org. There's a host of resources there to look at. One, if you want to do a little pilot program, fast-track key tasks. It's got 10 items that you go through, some documents there as templates that you might want to use, explanation of the authorities for sponsorship under federal law, Q&As of many of the common questions that we get. Those are available. Also, NIHB, in addition to Tribal Self-Governance Advisory Committee, NIHB has held seminars at their annual conferences, and so some of those materials are on their website, particularly identifying case studies. One is Central Foundation, another Chickasaw Nation that you could find. This slide here and the link to it, it's a one-page document that identifies the federal laws and that provide for the authorization of sponsorship, the requirements on the federal government on marketplace health plans in relation to sponsorship and who has to do what. So it's if someone at your tribe wanted to know, well, under what authority can we do this? Under Section 402 of the Indian Healthcare Improvement Act, it allows this, this, and this. CMS has then also issued documents, regulations pertaining to this as well. The Affordable Care Act has provisions and specifically indicate that certain things are going to occur. This one-page document summarizes those. Just taking a step back on this issue of sponsorship, back in May of 2015, there was the first joint meeting of the Direct Service Tribes Advisory Committee to IHS and the Tribal Self-Governance Advisory Committee to IHS. And in that May meeting in 2014, it was one of their joint initiatives that was identified was sponsorship. And the initiative was to educate, provide information to tribes so that they were aware of the potential available through the marketplace if a tribe wanted to secure federal resources through that mechanism, to emphasize that it's a choice of the tribes whether they wanted to do that or not. And then also to facilitate tribes in actually doing sponsorship and sharing best practices and the like. And so that's been happening since back in May of 2015. As noted on the slide there, in two recent survey of tribes, one found that 37% of those responding tribes reported that they were operating some type of sponsorship program, either Marketplace or Medicare or both. Some tribes, in fact, are sponsoring tribal members for their employer-provided insurance. So if they have coverage through their employer, the employee's contribution might be $100 a month, for instance, and that would then bring in the employer contribution at $300 or $400 to cover the remaining premium. So some tribes have said, we will pay that $100 a month to your employer, or we'll reimburse you for your payment, so that that's a third-party revenue that's coming into the mix, like bringing in federal resources. So again, two recent surveys, one found that 37% of respondents and another 52% of the respondents indicated that they were operating tribal sponsorship programs. So pretty broad penetration at the moment, and it seems to be increasing, using sponsorship as a tool. Just conceptually, this slide and the next one kind of shows how the idea of maximizing health insurance coverage has been working. I think intuitively you all know how it works, which is get coverage and be able to bill some entity rather than having to use limited IHS appropriation to cover the cost. But what this slide represents is, if we see the blue color, that represents some type of employer or federal dollars coming in, state dollars coming in to subsidize coverage of some tribal members. Others may have employer-sponsored coverage, Medicare, Medicaid. Some individuals are obviously uninsured, active users in an area that are uninsured. And then we have a bar on the right, which is shaded a bit differently, showing in a sense the potential that if the marketplace were accessed, if we can move just a portion of the dollars from of the appropriated dollars in individuals from the uninsured category over to the marketplace, we'd be able to pull down a bunch of resources from the federal government in the form of premium tax credits and cost-sharing protections. So we have a number of areas showing here where there's no colored fill-in representing gaps in funding, particularly for the uninsured. Many tribes are in a situation where the resources made available are not adequate to meet the healthcare needs of their tribal members. Leads many tribes to operate their purchase of referred care, PRC programs, not authorizing all medically necessary services, but possibly just authorizing priority 1 and 2, and showing how that rationing exists, limiting tribal members' access to health services that they readily need. So what this slide shows is that gap, that the appropriated dollars do not cover the full need of uninsured individuals. And in fact, in this slide, none of the appropriated dollars are showing in the marketplace bar. They're not being used to sponsor individuals in this slide. Whereas the next slide here, we show the appropriated dollars are allocated out to cover out-of-pocket costs to sponsor individuals in the marketplace. And it's then showing the uninsured bar shading, fully covering the whole bar there, representing those that remain uninsured at a particular tribe. If they're able to maximize use of the appropriated dollars to leverage federal funds, employer dollars, and others, they have an opportunity to maybe achieve close to 100% coverage. Those that remain uninsured, the appropriated dollar would be adequate to meet their full healthcare needs, such as authorizing all PRC services that are PRC reimbursement for services that are medically necessary. And if we look at trying to extend use of the appropriated dollars outside of those services that are typically covered under an insurance package to things such as prevention and community health shown on the left, or on the right-hand side, long-term care support services that are typically not covered by a standard acute care health insurance package. So tribes that are able to maximize basic health coverage, bringing in federal resources, employer coverage, things of that sort by doing sponsorship where it makes sense, frees up the appropriated dollars that were being spent on uninsured folks, and that those appropriated dollars then could be moved over, hopefully, to meet the healthcare service needs outside of the basic health insurance package. Just a couple slides about just how does sponsorship work, just the mechanics of it. This slide shows Medicaid enrollment and the steps there. So simply put, a tribe, IHS, Urban Indian Program may assist a tribal member to enroll in the marketplace, so they expend some effort and maybe some funding to hire staff to assist folks to enroll. Those folks then enroll in Medicaid coverage and then get services, either in the ITU system or from private providers. And then finally, the Medicaid will pay those providers for the services. Pretty straightforward. When we look at the instance for tribal sponsorship, we've got one additional box introduced into this, which is, again, the tribe would assist the tribal member or other IHS eligible individual that they may want to sponsor to enroll in the marketplace. So some effort put out there. The second step, though, that isn't needed under Medicaid is that the tribe would pay the premium, to the extent there is a premium, after the subsidy for premium tax premium tax credits. The tribe would pay the premium to the health plan, 1/12 the amount each month. Then the individual would enroll in the health plan and go get services, and the health plan, rather than the tribe's PRC program, would make payment for those services. So very similar process with Medicaid, except for the injection of the tribe making payment for the premium that may be due for the individual. The slide here just represents a few things. One is that when looking at enrollment in the federal programs, Medicaid is primary. If someone's eligible for Medicaid, they're not eligible for the premium tax credits or cost-sharing protections for the premium tax credits in the marketplace. In fact, though, enrolled tribal members, whether they're Medicaid eligible or not, if they went to the marketplace, they would still be eligible for the cost-sharing protections. But this aligns, how does it work, where you've got Medicaid coverage in a state, what might be the Medicaid eligibility level for children. We have then marketplace coverage to kick in above the levels for CHIP and Medicaid in the state. And folks might be eligible for tax credits up to 400% of the federal poverty level. The last two rows on this document just indicate if certain protections that the federal government has put in place through regulations would apply in each of these states. And the answer is they would. It's referred here as CSIO ECP contracting requirements, which is that for health plans offered through the federally run marketplaces, each of those health plans are required to offer a contract to Indian healthcare providers if those Indian healthcare providers operate in their service area. So that's a protection that's there in all the states wherein the federal government operates those marketplaces. Some states that run their own marketplace have put in similar protections for Indian healthcare providers as well. The last row there is just showing some examples of what the marketplace enrollment levels are at the moment. And you can see it state by state, with Oklahoma having the highest level. Montana, I think, is fourth nationally with the 1,128 individuals that are enrolled. We're going to go just a little bit deeper on a couple items, and that's eligibility for the tax credits, and then focus on the cost-sharing protections, Indian-specific cost-sharing protections, and some of the nuances there. Nicholas, I'm wondering how we're doing on time?
Hi, thank you, Donnie. So far, we're doing good with time. We have approximately 25 more minutes.
Okay, great. And if anyone has questions, they can type it into the question box.
That is correct.
Okay, excellent. So, eligibility criteria for marketplace coverage and specifically the premium tax credit. So, overall eligibility to enroll in a marketplace, pretty straightforward. You have to live in the state that, in which the marketplace operates. So, in Virginia, in California, what have you. You have to be in the United States legally, legal resident. So, you don't have the permanent legal status, but you have to be legally residing here. And then third, not incarcerated. So if you are in prison, you cannot enroll in the marketplace. You can, though, actually enroll in the marketplace from prison with a start date to be effectuated after you are released from prison. Folks that are in jail, which is typically a tenure of 1 year or less, actually can be enrolled in the marketplace, but it's prisoners that are not allowed to be enrolled in the marketplace. So that's for general eligibility to enroll in a marketplace health insurance coverage. Specifically now, though, eligibility for premium tax credits that you might secure while enrolled through the marketplace. Premium tax credits, the Costsharing Protections, are only available through a marketplace coverage, not outside of it. So in addition to being in the country legally, not being incarcerated and residing in the state, you also need to have an income for premium tax credit eligibility between 100% and 400% of the federal poverty level. If you're in a state that expanded Medicaid, that 100% would be increased to 138% generally, because if you're under 138 or below, you'd be eligible for Medicaid. If you're eligible for Medicaid, you're not eligible for the tax credits. Another requirement, eligibility criteria to be eligible for premium tax credits are that you don't have an offer of coverage elsewhere. So I just mentioned Medicaid, but as well as you're eligible for Medicare, the full subsidized coverage for Part A in particular, or for Medicaid, or if you have an offer of coverage from an employer that's considered to be affordable, then that would prevent someone from being eligible for tax credits. And it's not just the individual employee who might have an offer. If a family member of an employee has an offer of coverage, even if they haven't taken it, that's considered to have an offer of coverage and then prevents access to premium tax credits. Affordability of employer coverage is shown there. 9.86% of the household income would have to be expended on the lowest cost premium for single coverage. So total household income, 9.86% of that, is that greater than the amount of the lowest cost premium for the single coverage. That's the formula for determining affordability of employer coverage. In general, if an employer is offering coverage, it's almost always turns out to be affordable in terms of the way the formula works. The affordability is not, as the next bullet point points out, affordability is not measured by what it costs for, say, a spouse to secure coverage through an employer. It's only based on what the employee cost is for the employee-only single coverage there. So that creates sometimes a difficulty that someone can't afford family coverage because the employer might not be subsidizing it, but because the individual employee's coverage is considered affordable, it then blocks all the family members from coverage through the marketplace with tax credits. A couple other points, veterans, they can be eligible for the Veterans Health Care Program, which can be comprehensive coverage. So they can be eligible for it, but as long as they don't enroll in it, they can be eligible for tax credits if they enroll through the marketplace there. If someone is already enrolled in the Veterans Health Care Program, it's really important that they be educated that they'd be giving that up if they wanted to get the tax credits, and so they have to weigh whether they want to give up their Veterans Health Care Program coverage to get into the marketplace. For some individuals, that will give greater access if they give it up. For others, it may ultimately prove not to be beneficial. It would be preferable that they stay in their current Veterans Health Care Program. So it's kind of an individual decision Finally, there's no Indian-specific eligibility criteria for premium tax credits. There are for the cost-sharing protections, but not for premium tax credits. So now we turn to the cost-sharing protections. For enrolled tribal members, not all IHS eligible individuals, but for enrolled tribal members, there's the comprehensive cost-sharing protections that are available. So if there's a covered service under a health plan, that individual, the enrolled tribal member, does not have to pay a deductible or a co-insurance or a co-payment when they access services or at any point. It would be paid for by the federal government, would pay the health plan for those costs, and the health plan would pay the provider. So typically, the health benefits card that someone gets when they enroll in marketplace coverage, when they present that card, and provider's office looks up what's your co-payment amount, they'll see that there's no co-payment required because of the type of coverage that this enrolled tribal member has. Now, there are two types, and I want to just go over this a bit here because there's been some confusion about how this is, these two types differ and how they've been implemented. One's referred to as zero cost-sharing variation, and the other limited cost-sharing variation. So, particularly for individuals that themselves or individuals have helped others enroll in the marketplace. If you visualize yourself sitting in front of a computer screen and you're on healthcare.gov, the federally facilitated marketplace, and you're trying to assist somebody enrolling in coverage or at least seeing what the premium would be if they were to enroll, you'd go on and you'll be asked, number one, do you want to be considered for assistance, for enrollment assistance from the federal government? So federal subsidies, federal assistance. Do you want to be considered for that? You can either say yes or no. Generally, say yes so you can find out if there are any subsidies that you might be available for. Someone, though, might say, hey, my income is high, and I know I'm not eligible for premium tax credit, so I don't want to be considered for eligibility determination based upon financial assistance. So that's number one. You can click one or the other. If you don't want a determination made based on your income level, you would then be in the right column there, number two, limited cost sharing variation shown in green. You would still be, if you're an enrolled tribal member, eligible for the limited cost sharing variation of the cost sharing protections. And that would be 100% comprehensive. You just wouldn't be eligible for tax credit. So as long as you're an enrolled tribal member, you're eligible for the limited cost sharing variation no matter what your income is. If your income is between 100% and 300% of the federal poverty level, 100 and 300%, and you enroll in coverage through the marketplace, and you are an enrolled tribal member, and you are eligible for premium tax credits, you then get the zero cost sharing variation. So let me explain the difference between the zero cost sharing variation and the limited cost sharing variation. Both of them, cost sharing, which is the deductible, co-insurance, or co-payment associated with a covered service, are covered under both the limited and the zero cost sharing variation. The zero cost sharing variation, though, requires no extra paperwork. And that means that if you are an enrolled tribal member, have coverage through the marketplace, you go either to tribal or IHS provider, or you go out to a private provider. You do not need to present any information other than your insurance card to get those cost-sharing protections if you're in the zero cost-sharing variation. If you're in the limited cost-sharing variation, you need what is referred to as a cost-sharing referral from your tribal health organization or IHS. You need a cost-sharing referral from tribal organization or IHS, and you need to provide that to the provider to secure your cost-sharing protections. So you're going out to get specialist service, and you're in the limited cost-sharing variation, you need to get a cost-sharing referral from your tribal or IHS provider, and then you're able to access those cost-sharing protections. So it has that one step. Some tribes have simplified that at the point that they enroll folks in the marketplace and they are in the limited cost-sharing variation, they provide them right at the start of enrollment a a referral for cost sharing that covers, for some, it covers the whole year of coverage that someone might have in the marketplace, so that enrollee will have that piece of paper, and they can present that piece of paper as a limited cost sharing referral throughout the whole year. They just want to make sure that they keep hold of that so that they have it available when they need to. Other tribes or IHS might provide the limited cost sharing referral each time someone goes out to get services. That's kind of a judgment call for the IHS or tribal program, how they want to issue the referrals, but they can go narrowly, they can go somewhere in the middle, which might be based on an encounter. You break your arm, I'll issue a referral for anything related to that, or, again, as some tribes have done, they issue right off the bat a referral that's comprehensive for the whole year for any services the individual may need. This slide here talks about the different types of cost-sharing protections that are available, and kind of and what the difference is across the health plan offerings. Now, you might be familiar if you go on to get coverage through the marketplace. The health plans are organized by metal level: bronze, silver, gold, and platinum. And it's an important distinction of what the differences are and are not between bronze, silver, gold, and platinum. You see down below, health plans on different metal levels offer the same health benefits and the same provider networks, whether it's a gold version or a bronze version. So a health plan may offer two different plans, but each of those plans are then offered on different metal levels. So one plan will be the same at the bronze and the platinum level in terms of the health benefits and the provider network. The only difference that plan would have between bronze, gold, platinum, and silver is how much out-of-pocket costs they are. Bronze level, more out-of-pocket costs; platinum level, fewer out-of-pocket costs. The plan might then offer, the health insurance company may offer a second plan, and that plan again would work the same way, that it would have the same network, have the same benefits, no matter if you're in a platinum version or the bronze. Now, those two different plans that one insurance company offers could be different. They have different networks or whatever. But each plan itself, when it goes up and down the metal levels, is the same, except for the cost sharing amounts. So when an individual is an enrolled tribal member and they pay no cost sharing, what they want to do generally, not always, but generally, is enroll in the bronze plan where the cost sharing amount is the highest, or flip that over, the federal government will be making the greatest amount of payments, where only 60% of the average costs are paid for by the health plan, and the remaining 40% out-of-pocket costs, the federal government is going to be picking up that 40% of the out-of-pocket costs on average. Versus the platinum plan, the health plan itself and the premium that the enrollee pays cover 90% of the cost, only 10% are out-of-pocket. So if an enrolled tribal member enrolled in a platinum plan, the federal government will only be contributing 10% to the out-of-pocket costs. It'd be better if they were paying more. So enrollment in a bronze plan, the premium is lower to the enrollee, and the federal government kicks in more of the average cost there. So not a concern rolling in bronze versus platinum in terms of a narrower provider network. It's the same network. No worry about the health benefits being skimpier under a bronze than a platinum. They're not. It's the same benefit package. It's only the amount of cost sharing. And because all cost sharing is covered for enrolled tribal members, it's beneficial to enroll in the least costly plan, which is the bronze plan, to secure the maximum benefit coming out of the marketplace. Just a couple more slides here on how the marketplace works, and then we're just going to go to a couple examples of tribes that have used sponsorship. So on the slide here titled Summary of Benefits and Coverage, each health plan that's offered is required to prepare one of these documents called a Summary of Benefits and Coverage, or SBC. They're generally about 8 or 9 pages long, and they summarize how the coverage works through that health plan. In particular, how to cost sharing, what are the cost sharing requirements, and for what. And because of the Indian-specific cost sharing protections, the federal government has required each health plan to create one of these SBCs that explain the Indian-specific cost-sharing protections. So one SBC for a health plan would cover the limited, and an SBC would be created by the health plan that cover the zero cost-sharing protection. What we see on the screen right now is a zero cost-sharing protection plan, and it's showing how much out-of-pocket cost there would be, your cost if you use an in-network provider, your cost if you use an out-of-network provider. Both of them are zero. As long as the service is covered, the cost sharing associated with that service would be covered as well. One nuance on that is there's something called balance billing, which is not cost sharing technically in the way the insurance industry define these things. So the co-insurance, co-payment deductible, those are all cost sharing that are covered. But if you go to an out-of-network provider and the provider bills an amount that's in excess of what the health plan identifies as a standard payment amount, the health plan, reimbursed by the federal government, will pay your cost sharing related to what it's considered kind of its standard payment amount. But an extra or balance billing that the provider may impose has to be picked up by the enrollee themselves. So in going to get care, when you have these comprehensive Indian-specific cost-sharing protections, it is preferable to go to an in-network provider where there's no risk of balance billing. Or if you go to an out-of-network provider, you want to ask the provider, do you do balance billing? And if they do, you might want to consider going to a different provider where you wouldn't have that balance billing amount that you'd have to pay. We've got a couple slides which just represent in a different way the subsidies and how they work. And the first example shown on the slide is for an individual living in New Mexico, and their income is above Medicaid level, so how much would they have to pay if they go on the marketplace? The next slide is a household of 3 persons, all enrolled tribal members. Their household income is $45,000 a year. That's 17% of federal poverty level, and shows what the distribution of costs would be with the federal subsidy, what the family or the tribe on their behalf would pay for the net premium costs, how much out-of-pocket costs would be charged but the federal government would pick up. That's the second example. And then we have a third one covering each of those points. For a higher income family, they're at 94% of the federal poverty level, just under the 400% federal poverty level threshold. They're at 375%. So these 4 enrollees, all tribal members living in Richmond, Virginia, they were to enroll in the marketplace in 2019, living in Richmond. What would the cost be to them or to their tribe if the tribe sponsored them? So let's use this third example to walk through that. So it happens to be a family of 4, all enrolled tribal members. The 2 adults are 40 years old, the 2 kids are 15 years old each. They enroll in the marketplace. It is calculated by the health plan that if this family were to enroll in the marketplace, on average, for a family of 4 with these ages, total spending, and flip it around, total funding needed would be just over $23,000 for the year in healthcare expenditures, administrative costs, and things of that sort. So how are those $23,000 in funding and expenditures covered? A portion is from the premium that the plan charges, and the other portion typically is from out-of-pocket costs. Now those out-of-pocket costs, because these enrolled tribal members, it would be the federal government picking them up. But nonetheless, we have total costs are covered by the premium paid to the health plan and by the out-of-pocket costs that the patient typically pays. The shaded area below, $11,047, that's the amount of the premium tax credit that the federal government would contribute for this family if they enrolled in coverage this year in Richmond, Virginia, at this income level. So even though that they are fairly substantial income at $94,000 a year, the federal government would still contribute a little bit over $11,000 for their premium for the year. The amount of the premium that would have to be paid for by the family or the tribe, if the tribe were sponsoring them, would be just under $4,000 a year, just under $1,000 per person for the coverage, $3,977. So that amount would be paid monthly by the family or by the tribe on behalf of the family to get this coverage. So a little under $1,000 a year per person that enrolls in this family. The out-of-pocket costs on average, pretty substantial number, but this is what health plans project for this age of enrollee and enrichment in a bronze plan. They're a little over $8,000 a year in out-of-pocket costs to meet the healthcare needs of these individuals. Again, as we pointed out, enrolled tribal members, comprehensive cost-sharing protections in the marketplace. So for all covered services, out-of-pocket costs are covered, cost-sharing is covered. So on average, the federal government would be paying out for this family $8,000 a year. Put it all together with the premium tax credit a little over $11,000, the out-of-pocket cost protections by the federal government a little over $8,000. That $19,000 plus is 83% of the total funding needed would be paid for by the federal government, and the enrollee, their family, or the tribe on behalf of the enrollee and their family would contribute $3,977 over the year. So for $3,977, $23,000 on average is going to be provided in reimbursed health services. Those dollars either going directly to the tribal or IHS program, if that's where the individuals get their care, or savings in the PRC program if people need to go outside the tribal IHS system to get their care if it's not readily available within. So that leveraging of paying a little under $1,000 per person, take a comprehensive health insurance coverage that's more in the order of almost $6,000 per person over the course of the year, generates that return to the tribe by investing in the healthcare premiums of the individuals. On this slide, it also is from Virginia. It just shows a table with a bunch of different examples of what the net premium costs are for the family. So the figures that are showing in the yellow area there represent the total net premium costs for the family, however many individuals are enrolling. So if we look all the way, let's say, to the right, at 175% of the federal poverty level, the third line down or fourth line down, third line down in the yellow, all the way over to the right, if there's a 4-person household and they earn 175% of the federal poverty level, they would have no premium at all. If they were 200% of the federal poverty level, the annual premium for those 4 individuals enrolling through the marketplace would be just under $600, $150 a person per year at 200% of the federal poverty level. Which, if we look at our table from earlier, that's probably right around $50,000 a year. If we go up higher, you can see there's greater net premium costs, but make sure you divide that by the number of enrollees. 1 enrollee, 2 enrollee, 1 enrollee, 3 enrollee, 4 enrollee, in these different examples. That's the aggregate cost for the full family there. For some tribes, when they start a sponsorship program, they might start a pilot and see how it works. They might generate a table like this and say, well, I'm eyeballing it here, and if you're under 200% of the federal poverty level, you almost have no premiums except for one example here, the $229 for a one enrollee in a 2-person household. So a tribe can start off kind of conservatively, say we're going to enroll 50 people who might have household income under 200%, so that we stretch our dollars, see how it works out. There'd be almost no premium cost. The cost of the tribe would just be hiring a benefits coordinator or 2 to help do the enrollment. And then they could see how that works, and then they might want to expand eligibility to a higher income level. They can target sponsorship to enroll tribal members, to all active users, to lower income. It's their choice how a tribe might want to set that up in terms of the eligibility criteria, as long as it's within the broader confines of the federal use of the IHS appropriation or third-party revenues. We have on the next page just examples coming from Spokane, Washington, and Tulsa, Oklahoma. There's different results in different areas because these are based on what are the premium offerings across the plans and how the formulas work with those premiums that are offered. So year to year, the net premium cost can vary, but in general, as we referenced earlier, for each dollar spent by a tribe to do sponsorship of the health insurance net premium costs and the administrative costs typically generates between $4 to $5 in benefit in the form of savings of PRC program or actual cash revenues coming in. We've got just three more slides about case studies. I'm wondering if there are any questions.
Yeah, before we go into those case studies, Dominic, we have one question. Our question is, if a tribe is not running its health facility directly and IHS is, can they do tribal sponsorship in the marketplace? Again, if a tribe is not running its own health facility directly and IHS is, can they do tribal sponsorship in the marketplace?
Great question, thank you. So the short answer is yes. So all tribes, whether they are direct service tribes where IHS is running all the services for them, Title I contracting tribes where they may have taken and operating limited number of services, or they're full self-governance tribes where they've taken the IHS appropriation in total and are running all their facilities. Anywhere along that spectrum, a tribe can allocate resources, the appropriated funds, allocate a portion of those, or third-party revenues that they may have access to and allocate those. So in the instance where a tribe is not running any of its facilities, IHS is, a tribe could enter into a Title I contract with IHS, identify where the funding source would come from. That might be from the PRC program, it may be from the hospitals and clinics line item, and move a portion of that over in the form of Title I contract. The tribe would then run the sponsorship program. IHS itself doesn't run sponsorship programs, but tribes have the ability to do that. So thanks for the question, and it just confirms that, again, it's up to the tribal decision, and all tribes, no matter whether it's self-governance or direct service tribes, somewhere in between, have the ability to enter into sponsorship and have the ability to leverage the fixed appropriation and bring in more federal funds. So we've got a couple case studies. First is a case study with the Chickasaw Nation. In this example here, it shows kind of the guidelines of their program. The tribe assists eligible American Indians, Alaska Natives with the cost of insurance purchased through the marketplace, so they assist with the net premium cost. Eligibility criteria established are determined by income and need. Next is no cost to the eligible participant. So if they enroll, the tribe is committing to say that that individual will have no greater cost than they would have otherwise from participating. So the full premium cost would be covered. It wouldn't revert in any way back to the individual that enrolls. Eligible individuals enrolled in the marketplace have no cost sharing when receiving health services at the Chickasaw Nation Department of Health or when referred by the Chickasaw Nation to a facility, the Chickasaw Nation facility, to a provider in the marketplace plan. So it's indicating that Chickasaw Nation will coordinate that, working with the enrollee that they're sponsoring. And the Chickasaw Nation views it beneficial to the individual to do marketplace enrollment, both because they can get resources, reimbursement for services provided by the Chickasaw Nation, as well as it provides the patient with more treatment options when they're at home, as well as when they're traveling outside of the IHS or tribal system. They'd be able to access private providers and not have to wait to get the services from an IHS or tribal provider when they return home. So in this case study with the Chickasaw Nation, eligibility requirements be age 65 or younger, or actually under the age of 65, be currently eligible to receive services from the Chickasaw Nation facilities, be an enrolled citizen of a federally recognized tribe, so it's not limited to Chickasaw Nation citizens, but enrolled tribal members, reside in the Chickasaw Nation service area, meet program eligibility and income guidelines that may be established, have no other insurance, so if you already have an insurance option, then wouldn't be enrolled. For many tribes, no other insurance means including not having an offer of coverage from an employer. They don't want to discourage people from securing that coverage. And then also have filed a federal income tax return in the last year and intend to file it next year. Part of securing premium tax credits is filing an income tax return. Otherwise, any tax credits that have been paid out over the year have to be repaid. So it's important that folks understand that and commit to filing an income tax return. So the Chickasaw Nation has been operating this pilot program since 2014, so pretty close to right after the Affordable Care Act marketplaces were established. They've enrolled 213 patients, and notes here, high-cost medical and pharmacy. So in addition to the criteria, they particularly focus on folks with the greatest healthcare needs that do not have health insurance there. They happen to use the Blue Cross Blue Shield plan of Oklahoma, which is a preferred provider organization. So it has a network, but it's not a closed network. You can go in network and out of network. And then the return, ROI, the return on investment, has been 6.6 to 1, meaning for every dollar that the tribe invested in running the program and paying the net health insurance premiums, they received back $6.6 in benefit. The split on that for them, and it varies by the particulars of a tribe, how many health services, how broad are your health services you have available versus how much do you rely on PRC. For the Chickasaw Nation, of that $6.6 return for every dollar they invested, 73% of that $6.6 was in the form of actual cash collected, third-party revenues at the Chickasaw Nation. And then about a quarter of it was benefit from cost avoidance. Another way to say that would be from savings in the PRC program if all of those costs would have been covered by PRC when someone goes outside the health system. So spend a dollar, get $6.6 back, so that means 5.6 or 560% return on investment if you were to put it in the percentage terms there. For the Chickasaw Nation, that's a bit higher than the average, which would be more in the 400 to 500 rather than the 560% ROI. But many programs are increasing their ROI over time or increasing the net financial dollar amount as they enroll more individuals. The next example here, case study number 4, T-SHIP, is example that is taking place in Alaska, and they've allowed us to share some of the figures that they have. In Alaska, about 80% of the tribal health organizations are working together in a single tribal sponsorship program across the state. It allows them to have minimal administrative costs with one program director, financial analysts with that, and then they have the benefits coordinator that operate at the facility level, oftentimes coordinating with their role of Medicaid enrollment. So they have been operating this sponsorship program as well from 2014, right when the marketplace was opened. They have their eligibility criteria that they establish, as each tribe can establish their own. And the requirement, be an Alaska resident, be eligible for services from the Indian Health Service, not qualify for other health insurance, so Medicare, Medicaid, or private health insurance from an employer, agree to file an income tax return, and then sign an agreement. There's a document that the tribes in Alaska use that identifies what's the requirements, expectations for those that enroll in the program, and what is the requirements that and expectations and commitments that the tribes make to the enrollee as well. And so those are spelled out in an agreement. The to the extent that someone's income might change over the year, part of the agreement is that individual would inform the tribes in Alaska of what change in income that there is to see if they continue to qualify for the insurance, or if they have another change in their family status where they become eligible for Medicare, they become eligible for employer-sponsored insurance. All those things are in the mix there. So they have two eligibility components to their program in Alaska. One is based on income. So all those criteria we talked about in their household income is no greater than 400% of the federal poverty level. So that would mean that they would be eligible for tax credits, given the other criteria that are there. The second component, individuals can have an income higher than 400% of the federal poverty level and may be able to not meet other eligibility criteria on a case-by-case basis if they have complex medical needs and they're otherwise uninsured, so that the tribe may pay the full premium, someone not eligible for tax credits, but it still might be in the financial interest of the individual and of the tribe to do that if they have significant health care costs. So, you know, procedures for complex things could easily be $100,000 in a year. The premium might be $5,600 for the year, non-subsidized. So the sponsorship program in Alaska would sponsor the individual in those instances, even if they're not eligible for tax credits because their income may be too high or there might be some other reason for that. So on this slide, it shows what the return has been to the tribes in Alaska. It's broken out where we're looking at enrollees who had household income at 138% of the federal poverty level and below, and those above 138% of the federal poverty level. So the importance of that is these data cover the first 18 months of the program. At that time, the first 18 months in, so in the middle of 2015, the state of Alaska had not expanded Medicaid, so you had individuals under 138 that were not eligible for Medicaid. So the tribes sponsored many of those individuals, and in fact, so we have 534 individuals that were sponsored over the first 18 months who had an income at or below 138% of the federal poverty level. The majority of those individuals, in fact, were not eligible for tax credit because their incomes were too low, below 100% of the federal poverty level. The premium tax credits are between 100 and 400% household income. So for those at or below 138, the tribes were paying their full premium for almost all those individuals. For those above 138, the vast majority of those, they were eligible for tax credits there. So we can just look at the net result. If we look at the column to the right, in the bottom row, $6.3 million. That was the amount of cash collected from third-party revenues, from the plans that the individuals enrolled in, that came to the tribal health organizations, services provided at the tribal health organization. So actual cash in hand over the first 18 months for these 896 enrollees, it generated $6.3 million in revenue for these otherwise uninsured individuals. Secondly, as a point made below, an additional $1.5 million were paid to private health care providers for these 896 individuals over those first 18 months as well. The vast majority of those costs are likely savings from the PRC program, because the tribe would have had to pay out, would have authorized payment for those services. We can consider the narrower benefit of cash at 6.3 and the broader $7.8 million in benefit. If we look at the table again and just look at using that ROI, return on investment calculation, we see in the column to the right an ROI of 294%, so just about 300%. So the tribes put out $1, got that dollar back, plus another $2.94 for those that they sponsored under the program. If you add in the $1.5 million of PRC savings, that return on investment goes to 365%. For every dollar they put in, they get $1 back, and another $3.65 in either PRC savings or revenues to the facilities for otherwise uninsured individuals there. This again was for the first 18 months, and the program has continued in operation since then, and the results have increased. They've gotten even stronger over that period of time. The 435 individuals that their income at 138% of federal poverty level or less, they in fact then got moved into Medicaid when the state expanded Medicaid. And so now the tribes are focusing on people non-Medicaid eligible and have a enrollment level just about 1,000 individuals right now that are in the program. So that's what we've, a couple of case studies that we have, and I really appreciate the opportunity to review marketplace provisions for American Indians, Alaska Natives, and to the extent that tribes have take advantage of those opportunities and what the results have been. So thanks again, Nicholas.
Again, thank you, Donna, for your work on this. Again, this is Nicholas Courtney with the National Congress of American Indians. We will be sending this webinar out in the next few days. Please feel free to reach out to me at ncourtney@ncai.org if you have any questions. Thank you and have a wonderful day.